Andrew Dory. I'm a cardiologist at Christiana Care Health Systems. The name of the article, which will appear in the Mayo Clinic Proceedings, is Aggressive Measures to Reduce the Door-to-Balloon Time May Increase the Likelihood of Unnecessary Cardiac Catheterization. What we found is that we were trying to reduce our door-to-balloon time. This is increasingly used as a quality metric, and there was a lot of pressure to reduce it as low as possible. We already had a very good time of 75 minutes on average, and our institution made a decision to attempt to get this under 60 minutes. We did get it under 60 minutes, but what we found is that there was an increasing incidence of what we call false positive ST elevation, namely people who were taken to the catheterization laboratory with that suspicion, but in fact were found to not have ST elevation. This appeared to be associated with a trend in mortality upwards, because in reality these patients had something seriously wrong, some critical illness that wasn't a heart attack. And in the cath lab we are equipped to deal with heart attacks, but not most of the other things. So we felt that this was an unnecessary push, and what was happening is the clinical evaluation of the patients was being abridged in order to keep the door-to-balloon time low. Clinical evaluation is still important. Door-to-balloon time is important, but it is not. It shouldn't take the place of a comprehensive clinical evaluation. This can be done relatively rapidly, and comparison of old EKGs, a full clinical history from the family and paramedics. These things can be accomplished in just a few minutes, and if they're skipped, we often can end up with the patient in the wrong place, because there's this constant drumbeat in the hospital amongst cardiologists and emergency room physicians to reduce the door-to-balloon time. And what we've pointed out is that while important, that drumbeat can have negative consequences if it leads to unnecessary catheterizations, which have a downside to it. Oh, I think it means a lot for patients, because it means that they will be able to have a better chance of getting the right therapy. Since our work was started, there's additional research showing that below 90 minutes, reductions in the door-to-balloon time doesn't seem to offer much. The earlier data suggesting it was beneficial started with door-to-balloon times of 180, 240 minutes. So in that narrow range under 90 minutes, it's not a big deal. And importantly for the patients, if they have a non-heart attack problem, they will remain in the emergency department, which is the place that's best equipped to diagnose and treat other non-heart attack images. We are going to maintain our surveillance of this to be sure that our door-to-balloon time remains acceptable, but our what we call the false positive STEMI rate remains low. We did a quality assurance program to re-educate people about the high-risk groups that do not benefit from going to the cath lab. And with this quality assurance program, we have eliminated the increase in the false positive rate.
We hope you found this presentation from the content of Mayo Clinic Proceedings valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you will find access information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.